Here we go, Treadwell DVT back again with another anatomy breakdown, muscle by muscle, working deeper and deeper into that posterior forearm mini-series, those muscles that control the wrist, the forearm, the hand. Last time we talked supinator, that deep forearm rotator with that huge radial nerve relationship. Maybe we're shifting our focus digitally towards the thumb, looking at a muscle that matters a lot more than people realize. We've got our Abductor Pollicis Longus. One that doesn't look like much on paper, but plays a massive role in thumb positioning, wrist mechanics, and a very common clinical condition you've probably heard of or possibly heard of. So we'll break it down. We've got our origin, insertion, function, innervation, and of course, a few clinical tidbits to finish things off. Abductor pollicis longus is a deep posterior forearm muscle sitting alongside extensor pollicis brevis and extensor pollicis longus. Has a broad multi-bone origin with fibers coming off of the posterior proximal half of the ulna, the middle third of the radius, and then the interosseous membrane between the two. From there, the muscle belly runs distally and laterally, narrowing into a long tendon as it approaches the wrist. As it crosses the wrist, that tendon passes underneath the extensor retinaculum through that first extensor compartment. Important note here, APL often has multiple tendon slips. It becomes very relevant clinically. Distally, APL inserts onto the lateral aspect of the base of the first metacarpal, with some anatomical variation where slips may attach to the trapezium or blend with surrounding structures. So big picture, APL starts deep in the forearm, proximal, posterior, radius, and ulna, and ends by controlling the position of that first metacarpal, that thumb metacarpal. To that point about the thumb metacarpal, sort of a given with the name, abductor indicating abduction, pollicis indicating the thumb, and longus indicating that it's the longer of two similar muscles. The name literally translates to the long abductor of the thumb. So yeah, at the most basic level, Abductor pollicis longus abducts the thumb at the carpometacarpal joint. A very different movement from extension of the thumb, underrated, maybe a bit difficult to differentiate early on in the learning process, but abduction of the thumb is moving forward away from the palm, back to front. We don't want to oversimplify though. Functionally, it does a lot more than just move them away from the hand. APL also assists with radial deviation of the wrist, extension of the thumb, and helps position the thumb for gripping, pinching, and precision tasks. It's especially active during power gripping, pinch gripping, lifting or carrying objects, and any task that requires thumb stabilization against load. Rather than creating large visible motion, APL's real job is positioning and stabilizing that thumb metacarpal so the rest of the hand can do its work efficiently. Now, innervation-wise, we're staying in familiar territory, a radial nerve baby, specifically that posterior interosseous nerve. Abductor pollicis is innervated by that posterior interosseous nerve, that deep motor continuation of the radial nerve. Primary nerve roots are going to be C7 and C8. So, to quickly reiterate, our Abductor pollicis longus is innervated by that posterior interosseous nerve, the deep continuation of our radial nerve. Just like the entirety of the posterior arm and forearm, radial nerve baby, not any different from the others. Clinically, Abductor pollicis longus is most closely tied to a little known condition called Quervains tenosynovitis. Quervains is an overuse and load management problem involving that first extensor compartment of the wrist, where APL shares space with extensor pollicis brevis. Because both tendons run through that tight fibrosseous tunnel beneath the extensor retinaculum, any increase in load, repetition, or friction can become symptomatic. APL plays a major role here for a couple of reasons. Firstly, it's involved in thumb positioning and stabilization during gripping, pinching, lifting, and carrying tasks that people repeat all day long. Secondly, APL frequently has multiple tendon slips, which increases the bulk within that first compartment and can raise compressive stress during those everyday motions. That anatomical variability helps explain why some people develop Quervains with relatively modest workloads, while others can tolerate much higher volumes without issue. Quervains often presents as a pain along the radial side of the wrist, and it's worsened by thumb abduction, gripping, lifting, or sustained pinch, especially when you throw in that radial deviation of the wrist. That's why provocative tests that combine thumb flexion or abduction with wrist deviation tend to reproduce symptoms so reliably. Importantly, this isn't just a thumb problem, it's a wrist and thumb coordination problem, where poor positioning, excessive repetition, or inadequate load tolerance overloads that first dorsal compartment. So when abductor pollicis longus becomes symptomatic, it's usually not a pure weakness. It's more often about how frequently tendon is being loaded, how smoothly it's gliding, and how well that thumb metacarpal is being positioned under load. Effective rehab focuses less on aggressive stretching and more on restoring controlled thumb abduction, improving tendon load tolerance, and managing wrist thumb mechanics during real-world tasks. In short, if someone has radial-sided wrist pain aggravated by gripping, pinching, lifting, or repetitive thumb use, that abductor pollicis longus and the first eccentric compartment should always be part of that rehab conversation. So that's our abductor pollicis longus, a deep posterior forearm muscle with a huge influence on thumb mechanics and wrist function. It may not look super impressive, might not catch your ear when you hear its name called, but without it, grip strength, precision, and control fall apart really quickly. APL is yet another reminder that small muscles with tight real estate can often create the biggest clinical problems. Another one, man. Hey, much more in store. Even more to come. Stay tuned, stay locked. It's Treadwell DPT. I'll catch you next time.